We are in the Senate Committee on Health. Today is April 27th. We have 3 items on the agenda. Item number 3, SB 1283 Bates, however, will not be heard. Senator Hall will not be here today. For my SB 815, we have 4 expert witnesses to discuss the major components of the Medi-Cal 2020, the state's Section 1115 waiver. After that discussion, I will present on the bill. We will have a brief comment from the support opposition on the bill and then have a vote on the measure. With that, we still don't have a quorum. We'll go ahead and get started as a subcommittee. We're going to move on to item number 2, SB 1408, Allen tissue donation. Good afternoon and welcome.
Thank you, Mr. Chair and members. So I'm pleased today to present SB 1408, which we certainly hope will help to improve the life expectancies of people with HIV who need organ or tissue transplants by removing California's felony prohibition on donating organs or tissue while HIV positive. And I'm very pleased to accept the committee amendments to ensure that the bill conforms with federal law. So let's talk a little bit about the problem. First of all, there are more than 120,000 men, women, and children who are awaiting organ transplants to save their lives in the United States today. Now, while roughly 30,000 of them, there were about 30,000 transplantations that were performed in 2015, it's actually estimated that 22 people will die while waiting for organs every day. 22 people die waiting for organs every day around this country. Now, among those hoping to receive life-saving organs and tissue are a growing number of people who are HIV positive. And new effective treatments are giving a normal life expectancy to HIV positive people. With that, other typical chronic conditions such as kidney and liver failure have now, of course, emerged as challenges for which organ transplants are often the required treatment. So a 2011 study predicted that beyond the current available organ pool are an additional 500 to 600 potential organ donors annually who are HIV positive who could donate 1,000 additional organs to ready recipients. However, California law currently criminalizes the act of donating tissue or organs if you are HIV positive, even if the recipient of the organ is also HIV positive. Now, research conducted in South Africa and in the United States has illustrated that organ and tissue transplant from HIV positive persons do not negatively impact patient outcomes. Now, in 2013, the Federal HIV Organ Policy Equity HOPE Act was signed into law by President Obama with bipartisan support. The HOPE Act authorized transplants from HIV positive persons to HIV positive persons and directed the Department of Health and Human Services to develop standards for HIV positive organ transplantation. The act also amended federal criminal law regarding HIV transmission to clarify that such organ donations are illegal. And then in March of this year, very exciting to report that doctors at Johns Hopkins University in Baltimore performed the very first kidney and liver transplants between an HIV positive donor and an HIV positive recipient patient in the United States. So this bill simply updates California law to help meet the growing need for organ donations by allowing the donation and transplant of organs between 2 HIV positive individuals. This update will allow California law to reflect medical advances and conform to federal law. There's no opposition to the bill, and here to testify in support is Dr. Anthony Mills and Alejandro Contreras.
Thank you, Chair and members. Thank you for the honor of speaking to you today here on behalf of SB 1408. I'm an HIV doctor and researcher in Los Angeles, and I was a founding member of the board of the American Academy of HIV Medicine. I began my work with HIV in San Francisco in the early 1980s, battling a disease that was nearly uniformly fatal. We had justifiable fear about HIV transmission, and California needed a law that would make it illegal to donate tissue or organs, which would quite likely transmit a fatal virus. Today, in 2016, we live in a completely different world. Today, the life expectancy of a person living with HIV approaches that of the general population. It is very rare for someone with HIV to die from HIV or to die from any of the opportunistic infections that used to kill our patients who are living with HIV. Today, patients with HIV die of heart disease, kidney failure, and liver disease, the same illnesses that affect the general population. Treatments for HIV are life-saving, but they too can take their toll on these same organ systems. This is why SB 1408 is so important. It will allow individuals living with HIV to donate organs to other individuals who are also HIV positive. You heard the jarring numbers about how many men, women, and children die every day while awaiting the dream of an organ transplant. This bill would enable many HIV-positive people who need transplants to receive them, and the double gift is that it would also enable many more individuals who are HIV negative to also get their transplants, as many more organs will rapidly be available for these life-saving procedures. This is a new day in medicine and in the treatment of HIV. Please support SB 1408 and be a part of the miracle. Thank you.
Before we proceed, we need to establish a quorum, if you don't mind, real quick. Can we call the members, please?
Hernandez? Here. Hernandez here. Nguyen? Here. Nguyen here. Hall? Mitchell? Monning? Here. Monning here. Nielsen? Pan? Here. Pan here. Roth? Wolk? Here. Wolk here.
Quorum has been established. Please proceed.
Good afternoon, Mr. Chair and committee. My name is Alejandro Contreras. I am a member of the community living with HIV, and I am the health programs manager at a local nonprofit called the Gender Health Center. I've been living with HIV for about 8 years now. I am 30 years old now, and I have been on a regimen of HARRT for about the same period of time. And what used to be a death sentence, and it's still very stigmatized as, is now a manageable disease, right? I am able to live a happy, normal, healthy life. However, I am still unable to do a few things that are considered criminalized or illegal, like donating blood or organs or tissue. Permitting myself or someone else who is living with HIV to be able to donate organs or tissue to other community members living with HIV has the potential of saving hundreds of lives each year and shortening the donor list for many people needing transplants. There are so many exclusions that myself and other people living with HIV are faced with. But I'm a full citizen, and we are all full citizens wanting to give back and support other community members that need us. This is an act of social justice and altruism that I, as an advocate and a person living with HIV, can have the agency to help someone I know that maybe has felt and gone through the same feelings of shame and immutable sense that we are unworthy of the right to live and have a healthy life. This bill is more than about just donating organs or tissue. It is about destigmatizing HIV, decriminalizing HIV, and acknowledging that I am a full, overall healthy person and that I'm not damaged. Being able to be the potential recipient of a donated organ or tissue in the future is something that could save my life. I want to be afforded the same ability to be on the list to receive donor tissue or organs, or not having to wait any longer if an HIV negative person can't donate any organs or tissue to me. And for decades, it has been illegal to do any kind of organ transplant for or to an HIV positive person. And it was even illegal to do any kind of research, criminalizing myself and other community members that are living with HIV. And again, the HOPE Act that I hope that California will back as well, please go ahead and pass SB 1408 to save hundreds of lives of Californians. Thank you.
Thank you. Anyone else in support?
Good afternoon, Mr. Chair and members. Joe Michael for Equality California. We're proud to be a co-sponsor of this bill, and we can also state that although Positive Women's Network was not able to have a representative here today, they are a co-sponsor as well, and we respectfully urge your vote. Thank you.
Thank you. Please proceed.
Good afternoon, Craig Pulsfer from AIDS Project Los Angeles, also a proud co-sponsor of this bill, and the Los Angeles LGBT Center was also not able to be here, but also a co-sponsor of this bill here in support. Thank you.
Thank you. Anyone else in support? Any opposition? Support or opposition? Support. Please state your name.
Brian Ortiz on behalf of the ACLU of California in support.
Thank you. Anyone else? Opposition? Questions, comments from any of the members? We have a motion by Senator Wolk. Seeing no other questions or comments, would you like to close?
I really appreciate the testimony from the witnesses, and I appreciate the work from the staff, and ask for your aye vote.
Thank you. We have item number 2, SB 1408, Allen tissue donations, do pass as amended. Call the members.
Hernandez.
Aye.
Hernandez, aye. Nguyen. Hall. Mitchell. Monning. Monning, aye. Nielsen. Pan. Roth. Wolk.
Aye.
Wolk, aye.
Currently has 3. We'll place that bill on call.
Thank you. Thank you so much, Senators.
Okay, we're at item number 1, SB 815, Hernandez Medi-Cal Demonstration Project. We're going to do this slightly different than we normally do in a hearing. We're going to hear the testimonies of the different presenters at that time, and then I will come up, present the bill, ask for support and opposition, and then ask for a vote. So. Good afternoon, and if you can just, whoever decides to speak first, if you just state your name and then please proceed. Thank you.
Sure, thank you. Thank you, Chair, members. Mary Cantwell from the Department of Healthcare Services. So I'm here just to present an overview of the programs in the waiver renewal, and certainly I'm happy to have my colleagues here who are actually going to be doing the implementing of the programs that I'll be talking about. So our goals for the waiver renewal were really to build off the successes of the 2010 waiver, which was called the Bridge to Reform, which really laid the groundwork for California to lead the nation in the implementation of the Affordable Care Act. It also had significant funding for our designated public hospital systems that really allowed them to drive significant delivery system transformation to be better able to serve the hugely expanded population that we have for Medi-Cal today, over 13 million members and still growing. The renewal that we secured is called Medi-Cal 2020 and really reflects that we are looking to have the program look and feel different over the next 5 years so that we have a better program for our growing population. The renewal is for a 5-year period that started January 1st of this year and expires December 31st of 2020. Overall, the initial federal funding is for $6.2 billion over the next 5 years, and there's some potential for additional funding in one of the programs that I'll talk about momentarily. There are 4 major programmatic components to the waiver: the public hospital redesign incentives in Medi-Cal, or called PRIME, the global payment program, the whole person care pilot program, and the dental transformation initiative. In addition, as I'll talk about at the end, there are several reports, evaluations, and assessments that we're required to do. So the first program that I'd like to talk about is the PRIME program. So this really builds off a program we had in the 2010 waiver called the Delivery System Reform Incentive Payment Program, or DSRIP. It was an incentive payment program that was really a pay for performance. It helps support infrastructure and drive outcomes in the public hospital systems. It was the first of its kind in the country, and since then many states have implemented DSRIP programs or looking to implement DSRIP programs. As we looked to this waiver renewal, we really wanted to take that a much further step beyond what we had done in 2010. And so the PRIME program builds on the success of the DSRIP, but really adds significantly more standardization and more robust requirements and a much larger focus on outcomes, including clinical outcomes. In addition, it is expanded to be beyond just our designated public hospital systems, but also includes our district and municipal public hospitals. So the PRIME funding that's available, $700 million annually for the first 3 years for our designated public hospital systems, which are our county public hospitals and our University of California hospitals. And then initially $100 million a year for the first 3 years in federal funds for our district and municipal public hospitals. For both groups, the funding decreases by 10% in year 4 and 15% in year 5. The hospitals have submitted applications to the department to participate in the program earlier this month. We received 54 applications, 17 from all 17 designated public hospital systems, and 37 from the district and municipal public hospitals. Only 2 did not seek to participate in the program. As I mentioned, this time around, there's many more robust standards. That includes for the designated public hospital systems certain required projects and a minimum number of projects. For the district and municipal public hospital systems, since this is their first time participating, and they also are very different hospitals from our larger county and university hospitals, they are allowed to participate, but only have to participate in one project if they want to, but they can select more than one. And as you'll hear from the representative from the District Hospital Leadership Forum, many of them did select multiple projects. In addition, the district and municipal public hospitals, because again, this is their first time around, they are also able to receive funding for infrastructure metrics to help support their ability to actually be successful in these projects. In total, across the 54 applications that we received, the hospital systems will be performing 270 projects over the next 5 years that will result in better care and better health outcomes for our Medi-Cal population. The projects are grouped into 3 domains. The first is a focus on outpatient delivery system transformation. This time around, we and our public hospital system colleagues really wanted a focus on outpatient care because that is where we want people to be getting most of their care. We want to focus on primary and preventive care so that the scarce inpatient and emergency room services that we have are really reserved for people who need to be there, and also to be able to improve people's health and so that they don't actually end up into the inpatient or the emergency room. There are 7 projects that exist in this domain, 3 of which are standardized and required for the designated public hospital systems, plus they have to select 1 more. An example of one that they have to do is integration of physical and behavioral health, since it is such a critical issue for us. The other projects include things like focuses on prevention around cardiac care as well as cancer and obesity. The second domain is on targeted high-cost and high-using populations. The goal here was to identify projects that would really be focused on populations for whom we think there can be significant improvement in their healthcare outcomes and quality if we have targeted programs that are focused on them. There are also 7 projects in this domain. Again, 3 are required of all 17 designated public hospital systems, and they have to do 1 additional one. The ones that they are required to do focus on perinatal care and care transitions and complex care management. The other programs are focused on health homes for foster youth, as well as programs targeted at post-incarceration and other care transitions. The third domain is resource utilization efficiency. In this one, the designated public hospital systems must select one of the 4 projects that are available. These projects really focus on reducing misuse, overuse of certain technologies and drugs. So the 4 project areas focus on high-cost imaging, high-cost drugs, antibiotic use, and blood factors. The one other piece that really is new in Prime that wasn't there in DSRIP is a focus on a move to alternative payment methodologies. Both the department as well as the federal government is really interested in seeing movement towards value-based payment. So not just paying for services, but paying for value and outcome and sharing risk between payers and providers. So there's a requirement in the waiver that by January 2018, that 50% of the payments that are coming from our Medi-Cal managed care plans to our designated public hospital systems be in some form of alternative payment method. That includes things like capitation, bundled payments, things that have a component linked to values or outcomes. That percentage needs to grow to 60% by the end of the waiver. To support this initiative and to really continue to support the growing collaboration that we want to see between our providers and our health plans, there is a requirement under Prime that every designated public hospital system have a contract with at least 1 Medi-Cal managed care plan in their geographic area. The second program is called the Global Payment Program. This is something we're really excited about and that I personally am very excited about. It is also new and unique to California. It's another place where we're leading the nation in looking at how we fund care to the uninsured. Under this program, we're taking 2 previous funding streams, the Disproportionate Share Hospital Payment Program, which was focused on uncompensated care for Medi-Cal and the uninsured, and prior waiver funding called the Safety Net Care Pool, which was focused on uncompensated care for the uninsured. The program in the waiver is for our county public hospital systems, so our University of California hospitals will continue to receive DSH payments like they have in the past. Both the DSH and the Safety Net Care Pool funding were cost-based funding, so you had to have a cost and then you would get reimbursed for a portion of that. In addition, the bulk of the funding between the 2 programs fell into the DSH program, which is a hospital-focused program, so that funding was not available for non-hospital services. Both of these elements, the fact that it's cost-based funding and it was mostly hospital-focused, really limited the ability of our county public hospital systems to do the things that both they and we would like to see, that there be a better focus on outpatient care for the uninsured and be able to have things like health homes and primary care assignment for the uninsured. But what would happen if a county system decided to invest in its outpatient system is that there was likely not money available from these funding streams to fund primary care and preventive care for the uninsured, and simultaneously, if they reduced inpatient utilization because they were serving these individuals in outpatient, they would lose the DSH funding that they were receiving. So we wanted to remove the sort of misaligned incentives, and that's why we created this program. This program takes the funding that existed that was cost-based and hospital-focused and instead creates a global budget for each county public hospital system. And then that system can earn that budget based on utilization of services to the remaining uninsured. So it's completely focused on utilization for services to the uninsured. In order to receive their full budget amount, they have to provide a threshold level of services to the uninsured that was based on historically the level of services that they were providing. The utilization is going to be measured in a standardized way using what we're calling a point system. We've assigned the value of 100 points to a standard face-to-face outpatient visit with a physician. All other services then are relatively scaled to that 100 points. So inpatient is higher, certain less expensive and less taxing services are less than 100 points. Initially, the relative value of the points were set based on the relative costs of the services. But because we wanted to see a movement towards outpatient services for the uninsured, the point values for acute inpatient care and emergency room services will actually decline over the course of the 5 years. So that means that a public hospital system, if it just continued to do what it had been doing, would be unable to earn its full global budget. So there's a financial incentive and a drive to do what we know that they want to do, which is focus on primary and outpatient services. In addition, another piece of this program that we're excited about is that services that either previously weren't captured or reimbursable are actually being valued. We have point values assigned to those and can be used by the public hospital systems to provide these types of alternative services to the uninsured and get credit for it. These include things like technology-based encounters such as e-consults, telemedicine, phone conversations, email between the doctors and the patients, as well as other non-traditional services, including things like the use of community health workers, patient navigators, using paramedics to treat and release patients, as well as patient support groups and group visits for treatment of chronic conditions like diabetes. The federal funding for the Global Payment Program is a combination, I said, of DSH funding, so the previous DSH funding that the public hospital systems would have received, as well as in the first year, $236 million of federal funds that was in the safety net care pool in the prior waiver. As I mentioned earlier, there's a potential for additional federal funding. It's in this program. We only know that $236 million for the first year. If there is going to be additional funding in years 2 through 5 for that component, it's dependent on a report that we're submitting to CMS on uncompensated care next month, and they will use that to inform whether they will authorize additional funding for the program. The third program is the Whole Person Care Pilot Program. This is also a brand new initiative under the waiver. In this program, we want to test locally based initiatives that will coordinate not only healthcare, so physical health and behavioral health, but also social services for really high need, high using populations who are using multiple systems across our counties and providers, and they generally today have poor outcomes. The pilots will identify target populations, share data between their systems, coordinate care in real time, and evaluate both individual and population health progress over the course of the 5 years. There is $300 million a year in federal funds available under this program for a total of $1.5 billion. The public entities who will be in charge of applying for these will also be providing the non-federal match from their local funds. So we're really looking at the ability of these pilots to increase integration across county agencies, health plans, providers, as well as other community organizations that serve these high-risk and high-utilizing populations and develop infrastructure that won't only serve them during these 5 years, but will be there after the program is over. We want to see increased coordination and appropriate access for this most vulnerable populations that this targets, reduce inappropriate emergency room and inpatient utilization, really improve data collection and data sharing among entities, achieve targeted quality and administrative improvement benchmarks as well as health outcomes, and as well there's an opportunity to increase access to housing and supportive services. We will be seeking applicants for the program. The applicants have to be public entities, such as a county, a public hospital, a health authority, and we're currently seeking a change in the waiver to allow for Indian health clinics or tribal entities to also serve as lead entities. In addition to the lead entities, there are several required partners that they have to recruit and have participate. At least one Medi-Cal managed care plan, the County Health Services Agency, the County Mental Health Services Agency, at least one other public agency, and at least 2 other community organizations, although we are encouraging and will be providing more weight to applicants who involve the broad spectrum of providers and organizations who see this population today. The applicants will be identifying their target population, but again, we're looking for the target population to be a high-need, high-using population. So we're looking for things like people with multiple chronic diseases, people who have been in the emergency room multiple times in the year, people who have mental health or substance use issues, as well as those who are homeless or at risk of homelessness. Generally, the pilot payments will be supporting activities that build the infrastructure to integrate the services, as well as share data among the different entities participating, provide services that either aren't currently covered or directly reimbursed under the Medi-Cal program, implement strategies to improve integration and reduce unnecessary utilization of healthcare services, as well as link funding to particular outcomes that the programs are looking to achieve. I know that housing and supportive services is obviously of much interest to many people, and we were not successful in getting the direct federal support for direct housing payments that we had sought in the waiver, but there is still the ability to support the, housing through what the federal government has talked about in a letter that they released last year. This includes things like supporting people in finding housing, supporting them in being able to remain in their housing, as well as other transition services and providing services in the house as well. In addition, although it's not eligible for federal match, the pilot does allow for there to be local flexible housing pools that can be funded by local contributions from the participating entities, as well as if there is cost savings to the participating entities from what they achieve in the pilot, they can also put that savings into the housing pools, and those housing pools can be used to fund direct housing support. We are still in the process of finalizing the requirements of this program with the federal government and have shared out the draft application and draft selection criteria to stakeholders for their comment. We are hoping that if we get the final federal approvals for the additional attachments, that we'll be able to release that draft application as the final application in May, and would be looking for those to be due back in July so we can get this program underway. And then finally, the last component I'm going to talk about is the Dental Transformation Initiative. We are also really excited to have this piece in the waiver, as it's the first time that dental has been included in our Medicaid waiver. We wanted to include this to have a focus on pediatric dental and testing different methods of both value-based payment as well as some treatment and risk assessment methods. And this is a significant investment in funding. We have $750 million over the next 5 years that will all be available to go directly to providers, with the goal of improving oral health care for California children and really seeing an increase in both utilization overall, but also, as you'll hear about, a real focus on the increase of preventive dental services for children. There are 4 programmatic domains within the Dental Transformation Initiative. The first is the one that's focused on preventive services utilization. We have a target to increase preventive services utilization by 10 percentage points over the next 5 years. This will be an incentive payment program that all providers of dental services will be automatically eligible for and receive if they meet the particular requirements. The incentive payments will be paid for each provider who meets their own individual target for increasing preventive services utilization. So each individual service office location will have its own target based on its own historical baseline data. We are targeting that the incentive payment will be worth 75% of the rate that's paid for the service. So they'll receive the payment for the service, and on top of that, if they achieve the increase in preventive services utilization, they will receive essentially another 75% of the money. So as I mentioned, again, the goal is to get 10 percentage points over the next 10 years, so we're looking to target 2% next 5 years, so we're looking to target 2 percentage points for each year. The second domain is CARES Risk Assessment and Disease Management. This is a pilot program that will start in initial counties where they have a high restorative to preventive services ratio. So normally we would like to see more preventive services than restorative services. And then if it's successful, look to expand it after the first year. The intent here is to use a particular risk assessment model where a child is assigned to a different risk category, and then there's a specific treatment plan that risk assessment would lay out for them. The dentist will have to opt in to participate in this because there's certain requirements that they will have to meet. And then the incentive payments, again, they'll be paid for the services, but the incentive payments will occur if they complete the risk assessment and provide the services. The third domain is focused on continuity of care. Just like with physical health, people should have a dental home that they continue to go to year after year. And so we want to encourage that relationship in Medi-Cal. So providers will be eligible to receive incentive payments and of increasing amounts for seeing the same child for 2 years, for 3 years, for 4 years, et cetera. This will initially start in selected counties where we have lower participation among providers, and then we would be expanding after that. Finally, the fourth domain is focused on local dental pilot programs. So really what we're looking for here is for local communities to develop ideas about how they could look to achieve the goals of the first 3 domains. We are authorized to select up to 15 of these pilot programs. And the funding can't be more than 25% of the total $750 million that I mentioned earlier. The eligible entities to lead the local dental pilot programs would be counties, tribes, Indian health programs, or UC or Cal State University campuses, and they would be submitting an application to participate, working with their community to propose what it is that they would do and how the funding would flow. We just recently released a non-binding letter of interest for the local dental pilot projects to help us assess who would be interested in this and what kind of structures they would be looking for to help us inform the final application and selection criteria. We have been working overall with both CMS and a small stakeholder work group to develop all 4 of these domains and make sure that the goals that we're laying out are actually going to work for the providers who are participating in them. So then briefly, outside the 4 programmatic components I did mention, we have many evaluations, reports, and assessments that we are being required to do. We have to do an evaluation of all 4 components, and in some cases we have more than one evaluation we have to do. There's sort of like a midpoint and a final one. In addition, we have 2 independent reports on hospital uncompensated care and financing. That was what I mentioned earlier, the first one that's due next month that focuses just on our county and UC systems. There's one due next summer that will focus on all 400 hospitals and on hospital uncompensated care and financing broadly across all of those hospitals. And finally, we have a requirement for our external quality review organization to do an independent access assessment of access and Medi-Cal managed care plans, looking at the network adequacy and time and distance standards in the Knox-Keene requirements, as well as looking at a comparison to non-Medi-Cal lines of business to understand how access to care may be different between Medi-Cal and non-Medi-Cal lines of business. That assessment is also going to be informed by an advisory committee that will provide input not only to the design, but to the draft reports before they're finalized and released. We currently have out there an application for people to apply to be on the advisory committee. That application period is closing. We just sent out a reminder to folks, and so we're looking forward to have that advisory committee really inform our EQRO contractor in developing the access assessment. So with that, I will stop there.
Thank you. Who would like to go next? Oh, so we're going to do Sarah Mueller, Public Hospitals.